All right, so we just saw a patient that we diagnosed with delirium, and we've got a couple of minutes. Let's go ahead and just talk about a couple of the highlights about delirium, and yeah, you can ask some questions at the end. So let's see, first off, we can ask the question, what is delirium? I think that's a good high-level question. Delirium is a state of acute confusion. It can be caused by medical conditions, substances. More often than not, it's multiple things causing it. There's also a term encephalopathy that we throw around a bit. That actually describes the underlying pathobiology that presents clinically with things like confusion. Can also present with coma. They're not entirely the same, but delirium is the term we use in psychiatry because it has a good, clean definition. Next, what does it look like? What does it look like? Okay. Delirium, I like to think about this as the 4 A's. We could throw in a fifth, perhaps, if we want to be a little bit more inclusive. But first off, there's an acute change in mental status. By acute, we mean it comes on over the course of hours to days. And by change, we mean this isn't how they usually act. This is not their baseline. It's characterized by a disturbance in attention. Attention is, there are 3 different ways we think about that clinically. Can they focus attention? Can they sustain attention? And can they shift attention? So we know they can't focus if they're not making eye contact, and they're just kind of out in left field. Can they sustain attention? Those are the kinds of things we do at bedside, like asking them to give months of the year backward, days of the week backward, serial 7s, things like that. And shifting attention, if somebody has a perseveration, gives the same answer to different questions in succession, but not able to shift, and so perseveration is evidence of impaired attention. Next, there's an impairment in awareness, which is to say they don't really understand what's going on around them. It's kind of a gestalt, right? Are they confused? That's the confusional state piece. And then finally, there's kind of at least one kind of demonstrable cognitive disturbance. And so this could be in orientation, memory, executive function, you name it. So again, these are like the big A's of delirium. I said we could add a fifth, and so I'm going to say arousal. And so delirium is often hypoactive or hyperactive, so too much or too little arousal. You don't really get normoactive delirium. It's not a thing. So this is kind of what it looks like. We can ask about prevention. I think prevention is critical. I don't think we do a great job of prevention in hospitals these days, but there are 2 big models to know about. One is HELP, the other is the A to F bundle. HELP is a nursing and volunteer-heavy model that provides people with support if they have sensory impairment. They get socialization, ambulation, things like that. This is really in geriatrics to prevent delirium, improve recovery. And A to F is more of a critical care bundle. Won't get into the details here, but essentially they want people to recover faster, better. The D in the A to F bundle, it's an acronym. The D stands for delirium detection. And so it makes sense for this. And then finally, we could talk about treatment. And so treatment is really a broad category. I would say there are 2 parts to treatment. 1, we treat the precipitants. And then 2, we treat the neuropsychiatric disturbances. So the precipitants, obviously, how do you treat delirium? The answer is you treat the underlying cause. So if they have pneumonia, you treat that. Sepsis, you treat that. You name it. But really, the reason that we in psychiatry are consulted isn't the cause. Sometimes they want to know. We can help them kind of systematically go through that. But they really want to know, their behavior, their distress, things like that. And so broadly speaking, we could think about things like agitation. We could think about psychosis. We could think about, just amotivation or abulia. And so the agitation and psychotic symptoms, we often use antipsychotics, haloperidol, atypicals like quetiapine. Not a lot of great data. None of this is FDA approved, but in general, we're applying principles of treating these same syndromes from other conditions. We're applying it to delirium. And then the amotivation, I think, again, not great data on this, but occasionally if they're sleepy during the day, not getting up, we can do things like modafinil or a stimulant, like a mixed amphetamine salt, to help them stay awake during the day, engage in self-care, kind of get better, make sure that they don't have psychotic symptoms and so forth if you're using a stimulant. But yeah, and then there are some other creative approaches too, but I'd say those are the main things that we think about for managing delirium. This is an overview. What questions do you have?